Good afternoon. I'm going to share with you today about uterine fibroids embolization. It's a new technique for treating fibroids disease, and the title of my talk is Uterine Fibroids Embolization, to cut or not to cut. Now, what are uterine fibroids to begin with? They're actually common non-cancerous tumors of the uterus, and they're typically found in the womb of women in the childbearing age. In fact, it's estimated that 40 to 50% of women develop some form of fibroids in their lifetime. Now, fibroids are generally benign and they only need treatment if there are some severe symptoms. Many women have asymptomatic fibroids, no pain at all, and we generally recommend that we leave them alone. But if women develop symptoms, then they should be treated. Now, what are the types of fibroids that can be seen on ultrasound or MRI in the uterus or womb? There are basically four types. As you can see, there's the subserosal type, and these are the fibroids that lie inside the muscle but just peek out slowly just under the outer edge of the uterus. There's also the intramural fibroid that lie right inside the muscles of the uterus or right inside the wall. There's also a submucosal fibroid that basically grows and impinges on the uterus lining of the womb, and these just lie right under the uterine lining. And then there are those that are called pedunculated. The term pedunculated means to be like a stalk. So you can see they've got a stalk and they dangle sometimes from inside the uterine lining, or in some cases on the outside of the uterine wall or the womb wall. So the pedunculated ones are generally quite large, and depending on where they are, they can cause different symptoms. Now, what are some of these symptoms that we talk about? The most common complaint of fibroid symptoms are that of abnormal or painful menstruation. Some women find that their menstrual cycles are prolonged and they have very heavy menstrual flow, and sometimes the pain can be very unbearable, especially during the actual time of menstruation. Some women develop pain during or after coitus or sexual intercourse because the fibroid impinges and causes some pain. Frequently, we hear women who complain of bloating in the lower abdomen. They feel very bloated, a lot of discomfort, especially when the time is near for the menstrual cycle, for the menses to begin. Some women have constant heaviness and pain in the pelvis, especially on standing up, and it really depends on where the fibroids is. If the fibroids are towards the back, some of it can grow big and press on the back or the spine, and women complain of back pain. If they are on the front and they press on the bladder, some women find that they need to go to the toilet quite frequently. So whenever their bladder fills up, they feel they need to go. And that's because the fibroids are sort of impinging or pressing on the full bladder. Now, the most common way of diagnosing fibroids are ultrasound. Many women with fibroids who have seen a gynecologist and they've had a transvaginal ultrasound done. In fact, a transabdominal can also be done to see the fibroids, and they are usually about this size. They can be quite big, and you see is very well circumscribed or well demarcated mass in the uterus wall, and that is the fibroid. In this case, this fibroid is quite big. It's about 10.5 by 9 cm across, which is considered a huge size fibroid. Frequently for us, we like to do an MRI scan of the fibroids, and there are reasons for this. Now, the MRI to us is better because it first tells us how many fibroids there are, where they are located, whether they're big or small, whether they're pedunculated, whether they're submucosal, subserosal. But more importantly, it also tells us whether there are underlying problems such as ovarian cysts, such as endometriosis, such as any other masses in the pelvis. Sometimes an ultrasound may not completely see these lesions. More importantly, the MRI for us is important because it tells us whether the fibroid is just a benign lump or benign fibroid. In some very rare, extremely rare cases, there may be underlying cancers in these fibroids, or it may be a separate cancer altogether growing in the womb, a lesion known as a leiomyosarcoma. And so these can be all seen on MRI. So MRI is for us the preferred modality for evaluating fibroids. Now, What are the conventional treatments for fibroids? Traditionally, some drugs are given. So a group of drugs known as gonadotropin-releasing hormone agonists are given. And the idea is that fibroid growth happens because of a hormonal drive. A hormone is stimulating the growth of these fibroids, and they can increase in size, especially in women of childbearing age. So these drugs, GnRHA, help to block that hormone drive in the hope of shrinking fibroids. The fibroids may not shrink 100%. Some people, after using hormonal therapy for a while, may escape the therapy and the fibroids start to regrow because the hormones no longer become effective. And so all in all, about 50 to 60% of women can respond in some form to these GnRH agonists. Surgery is the other way of treating these fibroids, and they can be considered for severe symptoms. What do I mean? If the symptoms are very painful and very bad, some surgeons, gynecological surgeons, will recommend two forms of surgery. If the patient has got multiple fibroids or is close to menopausal age in their late 40s, sometimes surgery is done to remove whole or part of the uterus. Usually it's the whole uterus is taken out, and that's called a hysterectomy. Now, if the fibroids are not so many but are well demarcated, then sometimes just removing fibroids alone by making a cut in the uterus to remove that particular fibroid or the fibroids that are there can be seen. That's called a myomectomy. And this is a good procedure in the sense that it helps preserve fertility, does not remove the womb, and is recommended for women who desire to have children. The myomectomy can be done through open surgery or through laparoscopic surgery or keyhole surgery. Now, in the laparoscopic keyhole surgery, there's a keyhole incision made in the abdomen, and using a camera, small instruments are put in, and then the fibroids are cut onto and removed. Sometimes the fibroids are in the submucosal or they are in the uterine lining, like a pedunculated one. In that case, some gynae surgeons use hysteroscopic surgery, in which a camera is passed through the cervix and looking at the inside of the womb, and then the fibroids is just removed from the inside. There's a discussion about what is another procedure called a high-intensity focused ultrasound. Now, this is basically a new procedure. It's non-invasive, and basically what happens is under MRI and a focused ultrasound, ultrasound beams are targeted at the fibroid to cause it to basically break down and shrink and get smaller. It's also uterus preserving, and it really reduces the size of fibroids by up to 50%. Now, the procedure that I want to talk about today is called uterine fibroid embolisation. It is a minimally invasive procedure. It is not surgery, and it does not use ultrasound. What instead it does is we use fluoroscopy, and we insert a thin tube or catheter, and that is through a puncture in the groin artery called the femoral artery. And we pass these tubes under X-ray guidance, and we look specifically for the blood supply to the uterus, and then the smaller blood supply to the exact fibroids. And once we locate this blood supply, what we then do is inject small particles, and small particles, as you can see in this picture, and these are targeted at the fibroids, the blood supply that goes directly to the fibroid. So in other words, we are choking the fibroid off or strangulating its blood supply. What we do know are that fibroids are very vascular. That means they are highly dependent on this arterial blood supply. And so by choking off these blood supplies, by injecting particles, we essentially suffocate the fibroid and kill it off. This procedure is useful, especially in women who have multiple fibroids that are not too large. All right, and what you can see is after we do the procedure, the fibroids reduce in size significantly. For the smaller ones, they reduce in size up to 90 to almost 100%. For the larger ones, at least by 60 to 70% in size. Now, there's a bit of discussion about fibroids and whether they affect fertility. Now, there are many women who have infertility issues, and they have done all the checks, and they find that the quality of their eggs are okay, their partner's semen's count is okay, and essentially what they then have left are large fibroids. Some women basically have undergone fertility treatments, and have failed. And as a last resort, the conclusion is that the fibroids are physically causing the infertility. And what some women have done have been referred for surgery to undergo myomectomy to remove the fibroids before they have another attempt at in vitro fertilization or IVF treatments. We have in the last year done some cases where these patients were referred for UFE or fibroid embolization instead of surgery, in the hope that with non-invasive, non-surgical treatment of the fibroids, then at least the uterus is preserved for IVF. So what we have done for these patients is we have done the fibroid embolization. In the last year, we have done about 8 cases, and after undergoing UFE, 3 of these women managed to get pregnant despite failed previous cycles of IVF, and this was relatively within 6 months after we've done the UFE. So right now, there's no clear consensus on whether the uterine fibroid embolization procedure actually affects fertility, but this is on the flip side of the coin, where we realize that for these women who are already infertile and having a lot of problems conceiving, UFE somehow seems to have helped, especially if the underlying cause is the presence of large fibroids. Now, after the UFE procedure, what can the patients expect? Number one, it's much less painful than open surgery. It's very low risk relative to open surgery. We do most cases as day cases, and patients go on the same day. One of the things that patients experience maybe post-UFE is that they get an intense cramp in the abdomen, in the pelvis, like a very heavy menstrual pain, and it can be prolonged for up to 12 hours. So for us, the most important thing is post-procedure, we make sure the pain is well controlled. We use a combination of medicine, and patients are able to go home and get rest, and they feel better the next day. Now, what do we expect from UFE or fibroid embolization outcomes? As I said earlier, there's a reduction in size of the fibroids. For the large ones, as much as 60 to 80%. For the small ones, to almost complete regression. And if we repeat the MRI scans at about 6 months, you find that these fibroids are much smaller and non-viable. And so these are some things that can be expected in terms for UFE. Now, how do you know if you're suitable for UFE? First, usually women above 35 years old and non-pregnant who want to preserve their uterus for future pregnancies. We have done younger patients in their late 20s as well who decided not to go for surgery for fibroids. And key is they want to avoid open or invasive surgery. And then it's usually wise to consult your doctor or gynecologist. All right. Now, what we do know is after UFE, we recommend that a patient does not attempt to get pregnant in the near future, and that's within the first 3 to 6 months. And then we let the uterus heal and the fibroids to shrink down to size, and then they can attempt conception after that. So that about sums up my discussion and my presentation to you about a new technique for treating fibroids, uterine fibroid embolization. Thank you very much.